continue with the Professor Castro-Diaz was saying, we prepare slides of oral medication on what we have today, its combination of those better, and how to decide to move to another step. And the another step will be go ahead with Professor Ancona. So disclosures and the aims of oral treatment in neurogenic reducer overactivity is the presentation leads primarily to a specific issue in pharmacotherapy in neurogenic patients. You know that in this neurogenic subpopulation, the most important cause of urinary incontinence are both neurogenic reducer overactivity or incompetence in ureter closing function. Our aims are to decrease storage phase detrusor pressure, to increase bladder capacity, to restore irregular bladder emptying, and to get a tolerable or without post-void residual. And these are the aims of the oral medication, if we can get one. So these are the antimuscarinics, as Dr. Professor Castro-Diaz was saying again. They are difficult to treat this patient with antimuscarinics. We have to be very careful. But what is really important is these are the trials, investigation, antimuscarinics in neurogenic reducer overactivity. As you can see in the table, they are marked all the trials, and you can see in the table the solifenacin, that is probably the most investigated antimuscarinic in overactive bladder. You have only 3 trials for in neurogenic reducer overactivity, and darifenacin has no even one trial proved in neurogenic reducer overactivity. So we have no clinical research studies in this patient. Of course, oxybutynin is still as antimuscarine is still the most used drug. And to Madhavattas in 2013 published this review of safety and tolerability and efficacy in oral antimuscarinic, and I don't remember exactly, but he reviewed almost 3,050 30 reviews and maybe done 60 randomized control trials, and it says that large placebo control trials show that oxybutynin, propionate, that is known for in my country, and trospium, can lead to an increase of 30 or 40% in systometric bladder capacity and decrease 30 or 40% in maximum detrusor pressure. In other terms, more capacity and less pressure. This, as we were saying before, these trials has a bias because all based in urodynamic measurements alone, and other parameters were not accurately investigated, as for example incontinence in between catheterization of the patient or long-term data. I do receive patients that are in antimuscarinic drugs for almost 1 or 2 decades, and we don't know how it happened to these patients. If the question, what happened when a patient is in monotherapy with antimuscarinic fail and he start to be refractory, which is another term that we can discuss, that can I use double antimuscarinic? There is only 3 trials about that. The one by a man in 2008, he combined high doses of antimuscarinic medication, and he seems to, the appearance of side effects were comparable of that normal dose in monotherapy. But Nadeau in 2014 created a trial of dual therapy in children with myelomyelin and between combination of oxybutynin, tolterodine, and trospium, and he found that they are effective and tolerable in a few patients with neurogenic reducer overactivity by urodynamic capacity improved and maximal pressure of contraction decrease. But they have 20% of dropout patients for adverse events, so we have to take care of that. And the last one didn't neither proved efficacy of combination between monotherapy. So what we have, and was my colleague saying before, that you have to be very careful because antimuscarinic agents cross blood-brain barrier, so provoking cognitive impairment. Clinical trials are performed in patients with intact hematoencephalic barrier, so this is the bias of the research trial. But we have to know that maybe in stroke, in dementia, or another neurological disease, or another neurodegenerative disease, the blood barrier is not intact. So we do not how to these patients can provoke cognitive impairment in these patients with a blood barrier that is not healthy. And also, this population is probably elderly, so implications of drug-drug interaction may apply. At the same time, antimuscarinic produce a slow gastrointestinal motility, which potentially can alter the absorption of other drugs. At the same time, it metabolizes in the liver, so it competes with another drugs. And at the same time, some patients with dementia, for example, are under cholinesterase inhibitors, so who are more likely to be prescribed of bladder antimuscarinics, and then they have side effects, so they are probably be prescribed for another drugs for the side effects of the antimuscarinics. So here we have what is called in the geriatric prescribing cascade of medications. So to finalize with antimuscarinics, we say the antimuscarinic drugs improves bladder storage function, and this is true. They have high incidence of side effects, although controlled release have less side effects than immediate release presentations. In patients with cognitive impaired, antimuscarinics should be prescribed with a warning because there are proofs that oxybutynin cause significant memory deterioration. And we do have the new drug, this beta-3 adrenoreceptor agonist, this mirabegron, who have shown in only one clinical trial with 15 neurogenic detrusor overactivity due to spinal cord injury to provoke a bladder evacuation, improve incontinence decrease, and improve in bladder capacity, compliance, and storage phase, which make the mirabegron as an alternative in neurogenic detrusor overactivity, and if antimuscarinics are contraindicated, but cognitive impairment with this drug should not occur. And we must say that, of course, this is a trial that have lost a little follow-up, and the number of patients is only 15, and the nature of the study is retrospective, so we need more studies to occur these affirmations. What the guideline says, to finalize with this, antimuscarinic in the European guideline says for the first line, immediate release or extended release are the same. But the AUA and the SUFU in 2014 said that extended release should be used, should prefer over immediate release, because we know that extended release have less adverse events. But the NICE guidelines in 2013 have favored immediate release over extended release. Because of what? Because economic issues. So cost and economics are against, and the guidelines seems to not put into together with the same preparations. In terms in mirabegron, should be warned, as the European guideline says that patients should be warned and no statement at all. But the AUA SUFU is a second-line treatment when antimuscarinic failed, and for NICE guideline there is a third-line treatment. So there's differences between the guidelines, so they're not put into together. So, and there is no evidence or no says what combination of antimuscarinic or antimuscarinic plus mirabegron should be used. So, Furthermore, we could go through what is really refractory to pharmacotherapy or refractory to a drug, as we call second-line treatment, third-line treatment, or setup treatment. The IC guidelines says that to treat overactive bladder, non-neurogenic or the true overactivity, but overactive bladder, 3 months of attempting with the drug is enough to go to the second-line treatment. The AUA guidelines say that you can offer Botox stimulation of the tibial posterior nerve or sacral neuromodulation in patients counseling if they are referred to first or second line treatment, but they don't define what really refractory treatment refractory drug is. Even the FDA, of course, before the age of the miravigon, said the injection for adults with overactive bladder are approved but cannot use or don't adequately respond to a class of medication known as anticholinergics, but said nothing about a combination of anticholinergics or the use of miravigon. Of course, this is the, before miravigon. So, independently of the definition, the question is how do have to treat this patient when fail or they have a great adverse events. And for tell that second line of treatment, this is Professor Ancona that I would like to be presented. Thank you very much.